Thank you all for coming to our last session of Mini Med School this year. Um, just to give you a little heads up as to how this evening will go, we'll start with our typical intro talk by Monica, and then we will have a brief talk by some of our medical students, and then we'll actually go ahead and do some live ultrasound imaging so you guys can watch us actually scan. First, to introduce Monica. Monica Lyons is a second-year graduate student in the developmental psychology PhD program in Jessica Cohen's lab within the Department of Psychology and Neuroscience at the University of North Carolina at Chapel Hill. She is also a fourth-year MD PhD student in the UNC MD PhD program. Monica graduated from Tufts University in 2018 with a BS in Cognitive and Brain Sciences and Biology and a minor in Computer Science. After graduation, she worked as a research assistant in the Psychiatry Neuroimaging Lab at Brigham and Women's Hospital in Boston, using diffusion MRI to investigate neural markers of psychosis. She is currently interested in how applications of neuroimaging methods like graph theory can help us better understand psychopathology, particularly in pediatric populations. With that, I'll give it away to Monica.
Hello, everybody. I'm very excited to speak to you tonight. So like Paige mentioned, I do neuroimaging research, and so I'm really interested in how we can look at the brain using MRI. So I was really excited to talk today a little bit about different types of medical imaging that we use in clinical practice. Okay. So today we're going to talk a little bit about X-ray. Sorry, my pointer's here. We're going to talk about computed tomography, or CT. You might have also heard that called CAT scan. We're going to talk about magnetic resonance imaging, or MRI, which is the kind of research I do. And then, of course, we're going to talk about ultrasound. And then the rest of our session today is going to be focused on ultrasound. So first, we'll start off with X-ray. So X-rays are a type, oh, I don't know what happened here, but X-rays are a type of electromagnetic radiation. And so when you get an X-ray, a machine sends X-rays through your body, and then those waves either get absorbed or just pass straight through your body. And then we can read those X-rays on a detector or a screen behind your body. And so importantly, different types of tissues in your body absorb those X-rays differently. So some tissues, like your bones, have a lot of calcium, and so that absorbs a lot of the X-rays, and so that looks really bright on an X-ray image like this. And then other types of tissues just let the X-rays mostly pass through, and then those appear dark on the X-ray. And so these differences help us be able to get a picture of things like your heart, your lungs, all of that. And so this is what this picture is showing, essentially. Okay. And so when we look at an X-ray of the chest like this, some of the things that we're looking for, we're looking at the lungs, we're looking at the heart here, we're looking at all of the different bones. So you can see the ribs here, and we're looking at things like the diaphragm down there. We can also use X-rays for things like your leg. So you might have seen this in TV or movies, or maybe you've broken a bone before and you've seen your own X-ray. So X-rays are really great for looking at something like a bone. You can really easily visualize a break like this. So this is just a picture of how this leg is oriented in this picture here. When we think about X-rays, there are a few pros and cons to this type of imaging. So some of the pros are that it's relatively inexpensive compared to some of the other methods I'm going to talk about today. It's pretty quick, so we're able to get an image in a decent amount of time. And it has relatively low radiation. So those X-rays are a little bit of radiation, but it's pretty low compared to the next method that I'm going to talk about. Some cons of X-ray: it's a two-dimensional picture. So like what I showed you, when you're looking at the lungs, you're only looking at it from that one two-dimensional view. And the picture is kind of generally lower quality compared to some of the others I'm going to show today. Okay, and next we're going to move on to computed tomography, or CT, also known as CAT scan. So I want you to imagine this is a person, the top of a person's head. And I'm going to show you how CT works really similar to X-rays. So essentially, when you're looking at the way CT works is we have the same emitter emitting X-rays, and then those X-rays pass through the body, and then we have a detector on the other side to detect those X-rays. But then we do that again from a slightly different angle, and again from another angle, and again, all the way around in a spiral. So in the end, we're able to create a 3D image compared to just that 2D image that we get from doing an X-ray. So here, I'm going to show you what a CT scan would look like if we're scrolling through. So this is what the person looks like. We're scrolling through from front to back. So here you can see it's a little bit prettier than that other X-ray we saw before. You can see the spine coming into view there. And that's what the CT looks like. And you're able to get this beautiful 3D image of the abdomen here. Here's another view. This is, imagine this person here standing on their side. So we're scrolling through their side. And you can see all of those organs again, visualized in this really great 3D way. And then we have a final view we can look at. So this is, imagine that you're looking up at a person with their feet out facing you. And this is starting up high and then scrolling down towards their feet. So you can see this is their heart there. And then we're scrolling down, we can see liver, kidneys, all the way down until we see their legs. So a few pros and cons of CT. So you get a higher quality picture than that X-ray. You saw those beautiful images that I just showed that are 3-dimensional, which is another really great advantage of CT. And then in terms of cons of CT, it's a bit slower. So it takes some more time to take all of those pictures, spiral all the way through the whole body. It's a bit more expensive than X-ray. We have a whole big machine compared to a little bit of a smaller machine with an X-ray. And then there's a little bit more radiation with the CT. It's still a safe level of radiation. That's why we still use it in clinical practice, but it's a little bit more than you would have for an X-ray. Okay. Now we're going to move on to magnetic resonance imaging, or MRI. So here I have a picture of an MRI machine. It looks pretty similar to a CT machine. You can see it's got this spiral, it's got this circular shape. And then this bed moves in so you can take the pictures. But MRI takes a very different approach from X-ray and CT, in that it uses magnets to take pictures of the body. So without going in deep into the physics, essentially the magnet aligns atoms in your body, and then you pulse a radio frequency pulse to mess up that alignment. And then take the picture is basically just the energy released as that alignment relaxes back to where it was. And different tissues, just like all these other modalities, different tissues in your body do that differently. And so we're able to get a full picture of the body because of those differences. And then we're able to scan throughout the whole body and make that 3D picture just like we did with CT. So here's another example of MRI from that same view where we were looking with the feet down and you're looking up at their body and it's scrolling through. I want to see if y'all can notice anything special about this patient as we scroll. Okay. And I know that was very quick, so I'm going to go to the next one and see if you notice anything special in this next picture. So here, this is that view with the patient facing you, and you're scrolling through front to back. There's the MRI. And did anybody notice anything special here? If you had a very keen eye and you're looking very closely. So let me see if I can get up in here and click on it. Oh, it's not going to let me do that. Well, there's actually a baby in there, in that MRI. So maybe you're not a radiologist yet, but that's one really great thing about MRI is because it doesn't use radiation. It's really great imaging technique to use in pregnancy. Maybe, let's see. There we go. Do you see the baby right in there? All right, so a few pros and cons of MRI. So some of the pros, very high quality picture. As you saw, we were able to see really detailed tissues. It's 3-dimensional like CT, which is really great for visualizing things like tumors. And there's no radiation associated with MRI. It's just those magnets, so no radiation whatsoever. Some cons of MRI: it's pretty slow, takes a while to take all those pictures. It's very expensive. And that is it. So moving on to ultrasound, which is going to be the rest of our session here. This is just going to be a quick overview. So you might have seen an ultrasound machine before. You might have seen pictures like this, maybe in your life, if you've ever had an ultrasound on yourself, or you might have seen this in the movies. And so today we're going to talk about why ultrasound is a really great tool that clinicians have in their toolkit. So the way that ultrasound works is by sending out high frequency sound waves, from a thing called an emitter. So this here is an emitter sending out sound waves, and you'll see one of these in a little bit later tonight. So we then put this emitter on a person's body, and those sound waves propagate through their tissues, and then some of them bounce back right up to the emitter, and then we can read those signals as electrical signals. And importantly, just like with all the other modalities, different tissues react with the sound waves differently. So we're able to get a picture of what it looks like inside your body because those sound waves are acting differently with different tissues. Another really great thing about the ultrasound is we can then actually move this device to get different pictures in real time. And so you might have seen this in movies or wherever you've seen an ultrasound, where we can actually pivot that device to get different pictures and essentially get a 3D image. So a few pros and cons of ultrasound. It's relatively inexpensive, especially compared to things like CT and MRI. It's relatively quick, so we're able to get an image in real time. There's no radiation associated with it. It's just sound waves. It's portable. So you'll see here, we were able to actually bring ultrasound probes here. We would not have been able to bring an MRI machine or a CT machine for sure. And like I said before, we're actually able to get real-time imaging. So we see the image as we're taking the picture, essentially. A few cons of ultrasound: a little bit lower quality picture compared to things like CT and MRI. And it is three-dimensional, but we can't get the same amount of angles that we could get doing that full spiral thing that we do for a CT or for an MRI. But it's pretty good. Okay. And that is all I have for you. So this is a whirlwind through medical imaging. I'm happy to take any questions that anyone has, or if you want me to go back and re-explain anything that was confusing. Yeah. That's a great, very important question. Yeah, so contrast. Oh yeah, I'll repeat the question. So some folks in the audience have heard about contrast with some of these imaging techniques in things like Grey's Anatomy. So contrast is basically a really great way to something that we can really easily visualize with some of these techniques. So something like a CT, when you inject something like contrast, it will show up really, really bright on a CT. So that's something that we can use to visualize specific structures in the body because it shows up so brightly. Other questions? Yeah. Yeah, but beyond cost is what you said? Yeah, so any other considerations beyond cost when choosing them? So yeah, absolutely. So a lot of times the speed with which you can get them is important. So, and really all of the things that I talked about are considerations that clinicians are thinking about when they're picking which modality. So for example, if you're in the emergency room and we want to just get a really quick picture of how your lungs are doing something like an X-ray is going to be better than doing something like a CT because we can just get it really quickly. Then like I mentioned earlier with the portability, maybe you aren't able to get the patient all the way to the scanner. Ultrasound right at the bedside is going to be a better thing to do, not considering cost, but just thinking about the mobility of your patient, for example. So we are essentially weighing all of those different options And we want to just get the best picture that we need for the scenario. So sometimes we need a really nice, pretty picture in order to visualize something. So we're going to get the more fancy MRI. Or if the patient is pregnant, for example, we're going to opt for the MRI because of the radiation. That's a good question. All right. Thank y'all so much. All right, so now we're going to move to the next part of our session. I'll go ahead and close this down.
Yeah, so we're just going to take about a 5-minute break so that we can swap over and get all of the technology set up, especially for the live scanning. So feel free to hang around, go on a walk, get some more snacks. We'll be back in a second.
You guys have questions about
Okay, I think we're going to go ahead and get started again. As you can see, I have several people standing up here with me, so I'll do a very short introduction of all of them. First, we have Dr. Kristen Olinger, who is an assistant professor of clinical radiology at UNC. Dr. Olinger completed her medical school and diagnostic residency training at the University of California, Los Angeles. Subsequently, she completed her abdominal imaging fellowship at the University of North Carolina. Dr. Olinger became a doctor to combine her love of science, desire to provide compassionate care for patients, and opportunity for continued learning, which she is helping us out with today. And then also up here with me, we have Gaston and Ruthly, who are both Gaston's a 4th-year medical student, and Ruthly is in the MD PhD program, a 5th year now. And they're both a part of the scholarly concentration on ultrasound, so are really focused on having a better understanding and using it even more so in clinic than the rest of us. So I'll hand it over to them.
Thank you so much for that introduction. Well, last chance. Anyone have any other questions about the modalities before we move on to ultrasound? I'm happy to answer it now or afterwards as well too. Question? Great question. So when would you ever pick a CT scan over the MRI when you can avoid radiation? So in some scenarios, especially like in the setting of trauma, for example, if you've been in a motor vehicle accident or something terrible has happened, in those situations, we have to get images as quickly as we can. And we need really complete views to see, is anything broken? Is anything bleeding? Is anything bad enough that you need to go to surgery? And in those situations, an MRI wouldn't be able to give us the full body imaging we need in a fast enough time to be able to get those images. Sometimes CT can be helpful over MRI if you're looking for certain types of pathology. If you have infection and they want to see if you have an abscess and they need to drain something, sometimes CTs actually might be a little bit better than MRI in some situations. Sometimes, I know we talked about radiation and MRI for pregnant patients. With MRI, we can't give that contrast agent in a pregnant patient because it crosses the placental barrier and can be deposited into the fetus. So in those situations, if there's a patient where we're trying to figure out, is this cancer or is this something more benign? And they really need to know before a baby is delivered. In those situations, a CT might be indicated to make the diagnosis. So there are very specific clinical scenarios. And I think Monica did a great job of talking about pros and cons of all the different modalities. And those are definitely huge features that your clinician or your doctor is considering when they're putting an order in for you or for one of their patients. But a lot of little tiny nuances to the clinical history can be really helpful to figure out what is the best imaging for my patient. Great question. Yeah. Yeah, great question. A CT we can get within a few minutes, sometimes a minute or two even. We can have the patient hold a breath and do a full CT chest, abdomen, and pelvis and be done. MRI, if you're looking for chest, abdomen, pelvis of an MRI, you're looking at upwards of an hour or more for that study. So you can imagine if you're not feeling well, the thought of having to sit in the magnet for an hour while you get your images, I mean, just even when I'm feeling well, that doesn't sound like a fun time. So it can be significant differences in time depending on how much of the body needs to be imaged, right? If you're just doing an MRI of a brain, that might be a little bit faster versus something doing like a full chest, abdomen, and pelvis, or a leg or an arm, or so on and so forth. Great question. Anybody else? Okay, well, now that we have all the other modalities out of the way, let's focus our time on ultrasound here. So a little background, I know we have a little introduction, but I'm one of the abdominal radiologists, and I have completed all my training in diagnostic radiology. So a diagnostic radiologist will have training in all the modalities, all the different body parts, all the different patient populations, from peds to adults and beyond. I have focused my training on abdominal imaging, so I really focus everything below the diaphragm. The lungs are great, the heart's great, but I prefer things below the diaphragm. So, so my fellowship training was really focused on getting more experience with learning about MRI of the abdomen and pelvis and how to use that to guide, diagnosis for cancers in the abdomen and pelvis, how to guide, more complex cases that what would be expected from just a general radiology training. So I've done all the modalities, but really focused my learning on the abdomen. Okay, so what are we going to be talking about today? Well, this is a brief outline. We have just, what is ultrasound? And some of this I'll skip through because I think Monica did a great job of describing a lot of the basics behind ultrasound. Talk about some of the common uses we have for ultrasound, what you might expect if you're a patient getting ready to have an ultrasound, or, how do we explain to a patient how to get prepared for an ultrasound? We'll take a quick look at the equipment and the procedure of what's involved in getting the images. How do you interpret it? Who interprets it? And benefits, risks, limitations to ultrasound, as well as I'll talk a little bit about what else can we do with ultrasound besides making a diagnosis. We can use it for interventions. We have new emerging technology with contrast enhanced ultrasound. And we'll finish it off with some demonstrations of scanning, which Ruth Lee and Gaston are going to help me out with, and open it up to questions. And if you feel comfortable, you want to come up and see the probe that we have, I encourage everyone to come on up. Okay, so what is ultrasound? I know a lot of what's in movies and on TV, you think ultrasound, or maybe personally, if you've had an ultrasound, you might think, okay, well, it's obstetrical ultrasound or ultrasound of a baby when in setting a pregnancy, but it really is so much more. We are using our sound waves to produce pictures inside the body, and we can use it for things like diagnosing disease. We can use it for guiding us when we're doing procedures. We can also use it for therapeutic interventions. And I'll talk a little bit about that as we go into the emerging uses of ultrasound. So just a show of hands, who's had an ultrasound personally? Okay, yeah, so I would assume that seems about right. Ultrasound is pretty commonly used. Has anybody been surprised by their experience when they went in to get an ultrasound, where they felt like they weren't sure what was going to happen? And if you feel comfortable, or you want to tell us stories about what your experience has been with ultrasound. Yeah. But they also wanted to and they actually so we're not sure if I will. So that was really yeah. So I might not have any headaches. It might be I'm not really sure why. The lady who was that sounds like a very interesting experience, right? As a patient, that if you I know if you haven't been through medical school or you haven't had a diagnostic radiology residency, you might think, oh my gosh, why can't you find it? And I think that's a really good point you bring up about some of the issues with ultrasound. And I know we talked a little bit about some of the cons, but sometimes some things are just really hard to see with ultrasound. And that's because of the way that the ultrasound works and on one half. And I'll talk about some of the limitations, but also sometimes there's bowel in the way, like there's gas in the way, and that's a problem for ultrasound. And so things that are deeper inside the body might be harder to see by ultrasound, or things that have something in the way of it are going to be harder to see by ultrasound. And on the other hand, if you had a CT, you might be able to see all the organs, within the deeper layers of the abdomen. So that's, I think, a really good point of trying to figure out what are the limitations of ultrasound, and can we always expect to see the appendix? Oftentimes not. And so I'm not going to give any medical opinions here, and I recommend you consult your physician. But the ultrasound is a great first step for a young patient. You're worried about appendicitis. If you can spare them radiation and find an appendix and see it's abnormal, you can make the diagnosis, and then you don't have to have the CT. So it's also a good point of like, how can we use these modalities together to maybe see if we can avoid one? And if we can't, and if you're really sick and you needed a CT, then you could go on to CT after that. Great. Thank you so much for sharing too. So, I mean, there's lots of different reasons people have ultrasounds. You have pain somewhere, you're not feeling well, you maybe had another study and they found something on that study and they want you to follow it up with ultrasound to see if it changes over time. There's lots of different reasons you might have ultrasound, or why we might recommend an ultrasound as a radiologist. So we talked a little bit already about the basic principles of ultrasound. I have the probe over there, you can grab it, but basically, I'm gonna bring this with me for a second. I mentioned that there's an emitter, a transducer, and this structure, this thing, very expensive actually, because there's crystals and very special crystals in here. I always tell my residents, like, don't drop it. This is very costly. Maybe not as costly as a magnet for an MRI, but it uses this transducer to create high frequency sound. And the transducers can be at different levels of frequency. And there are crystals in here that move. And when the crystals move, that forms a beam. And that beam is then, basically transferred as sound waves that move through or propagate through the body. As we mentioned, the waves move through, they meet something, whether it be bone, soft tissue, an organ, fluid, gas. It can meet into something, and then it's either reflected or it can sometimes be a little bit resorbed as well. But everything that's reflected is reflected as echoes. That comes back towards the transducer, which then converts it into electrical impulses. And those electrical impulses are then created as an image on the computer screen that we have. So why would we use it? When would we use ultrasound? There's a lot of different reasons. We use ultrasound often for superficial things that are very close to the skin surface, to identify abnormalities. Things like if you have focal swelling, redness on your arm, and you're worried maybe you have an infection, let's take an ultrasound on it and you can see if there's fluid there or an abscess or if it's just, inflamed. Ultrasound is very commonly used with breast imaging, especially in cases where if you have a screening mammogram or mammography, that if they see something that they want to investigate it further, ultrasound might be your next step to see if there's any sort of breast nodule or any breast cyst, for example. And we use, in the abdominal world, I use it for evaluating the thyroid and the parathyroid. So that's the one area above the diaphragm that I also do, is just in the neck. We skip the chest. And seeing, is there a thyroid nodule that needs to be biopsied? Or is there a parathyroid nodule that might explain why your calcium level is really elevated or really low? We also use the ultrasound for deep structures. We can see the heart and blood vessels, the liver, gallbladder, spleen, all the abdominal organs like the kidneys and the bladder. And then the reproductive organs. Ultrasound's really great for evaluating the reproductive organs because it has really good soft tissue definition. We can see it. We can also check for things like blood flow to those organs that are very important. And we don't have to use any radiation. We don't have to worry about providing radiation to those typically more radiosensitive organs. So we use ultrasound for a number of these different reasons on a day-to-day basis in our radiology department. So what do you expect for a patient if you're about to get an ultrasound? Well, the good thing is there's really little to no special preparation. There are some scenarios where you might be asked to prepare slightly for this exam. Typically, patients will come in and we'll have them in a gown or even loose fitting clothing is fine. And we're going to scan and scrubs and it works. The gel typically doesn't stain. It just, we wipe it off right afterwards and you go on with your day. So sometimes if we're looking for things like the gallbladder, if there's a gallbladder abnormality, maybe you have gallstones or they're worried that you have an infection of the gallbladder, which is what we call cholecystitis, we might ask you not to eat or drink before the study for a few hours. And that idea is we just want to get the gallbladder nice and full with the bile so that we can see the best images of the gallbladder and make the diagnosis. Same thing for things like bladder or pelvic imaging. We might ask you not to urinate before the study for an hour or two, or we'll have you drink a bunch of water right before and try to hold it. And that's the idea of just trying to, distend the bladder, make it as big as possible so that we can see if there's anything abnormal. So typically, that's pretty much about all the patient preparation we have. Otherwise, there's not much in terms of having to go through enemas or taking, a bowel regimen or drinking something other than, or any sort of like IVs. For most of these ultrasounds, this is it. Okay, so we talked a little bit about the transducer already, but what other equipment do we have? Well, I think the first person and very, very important person to mention is the ultrasound tech. And so these are people who are trained to obtain the images on the ultrasound of a patient, depending on what the order is. So these, the ultrasound techs will take pictures, take the images, and oftentimes if the radiologist is in the same department, they'll come back and they'll ask us, I have these images, is this enough? Or I see something, I'm not sure what it is, can you tell me, or come in with me and scan, and we scan together. So the tech is really wonderful to help us get the best possible images so that we can make the diagnosis. So they are extremely important individuals. Then we have the computer console with the video monitor. So I mentioned all of the waves that are sent out by the transducer and that come back to the transducer are turned into electrical impulses that are then creating an image on our computer. So we need the computer console and the monitor, which is typically appears like that. And I know Monica included a picture as well. And you'll see that next to the bed for the ultrasound. And then finally, we have transducers. So I show you this one because this is a butterfly probe. This is something handheld I can take with me. As you see, we have it hooked up to an iPad. You can hook it up to an iPhone. It's really wonderful, especially for places that maybe are resource limited, right? We have a global radiology program at UNC for global radiology, particularly in Malawi. And so in Malawi, they don't have an MRI magnet. So what can you do? You can take an ultrasound, you can take a butterfly probe and provide diagnostic medical imaging for a location or for individuals who might not have access to some of the other modalities that we have. But there are lots of different, there's lots of different transducers we use. These are just some examples: phased array, linear, curvilinear. I'm not going to get into all the physics. It has to do with the shape, as you can see, of the transducer. And then we also have the endocavitary, which is for things like pelvic imaging, for like endovaginal ultrasounds. So lots of different potential transducers you might see. And with all of these, you have to use gel. And I have gel up there. And basically what that is, why we use it, is because we don't want air to get between the edge of the probe and the patient's skin. Air is a problem for ultrasound. Ultrasound does not like air. It can't go through air. It's not just going to randomly make sound waves and go on through. So we have to create a barrier, so something that keeps the probe surface in contact with the skin surface. Same thing with air being a problem deep in the body. If you have a lot of gas in your bowel and that's, in the abdomen, it might make it hard to see some of the deeper structures. Okay, so we have our gel. We put the gel on the probe. We take the pictures, and we usually take pictures in multiple different ways. As mentioned before, you can move the transducer, you can curve it around, you can slide it up and down, you can turn it in directions so that it changes the image that you see. On CT, it's really easy to show examples of, well, this is looking at the patient directly on, as we saw on that MRI with the baby, for example, or, looking at the patient from the side and seeing, that's what we call a sagittal view. But with ultrasound, we have a little bit more mobility to taking pictures. We still try to take pictures in similar planes. We try to take pictures like short axis or cross and then turn it so that it's perpendicular, 90 degrees, or long axis. But we can do it in lots of different ways here with ultrasound. And that is different from what we have available to us for CT, MR, and X-rays, of course. And really, most of these studies are painless, they're fast, they're well tolerated. You may feel a little bit of pressure, but the great thing is, because the ultrasound tech is there scanning with you, you can talk through it and say, hey, that hurts a little bit. Can we get a little less pressure here? Or I can handle that, it seems fine. And so there's a lot more interaction during the examination. Okay, so we have a couple different ways that we can get pictures. I show these 3 examples because this is one benefit of ultrasound, is that we can see real-time imaging. We can see real blood flow. So the far left image is what we call our grayscale image. And this is just a black and white image, static, one single picture showing. On this one, we can see, I don't know if you can see my mouse. So my mouse is hovering over the liver here, and this is the kidney. We're looking at it kind of in a long dimension here, and we can see things about how gray it looks. Basically, that's what we call echogenicity. We can see if it's really, really dark or anechoic, it's fluid. If it's brighter, it's usually more solid tissue. And we can see just the organs, in relative to each other. On this middle image is what we call the color Doppler. And this is a special feature of the ultrasound that we can turn on, and we can see flow. And typically it's vessels, vascular structures. So arteries or veins in the liver here, we can see them fill with these little blips of blue color, right? Here, little one here, and right here. But we also see some other structures like this, but that doesn't fill. So if it doesn't fill, we know it's not a vessel. It might be something else in the organ that is not a vessel. In the liver, this is a bile duct. And then we can go even further and say, well, I see there's flow in that vessel. That's good, especially if we're trying to make sure there's nothing like, thrombus or a blood clot. So we can say, okay, well, there's flow. That's a good sign. We can tell more information. We can see how fast it's flowing and what direction it's flowing as well. And so this is just another extra layer onto our ultrasound called spectral Doppler. So we have a lot of information just from this one study. This type of information is not something that we could necessarily get to the velocity, like the speed of the vessel. That's not necessarily something we could get from CT or MRI. We could see if there's flow to something with CT or MRI if we give contrast, but we are not going to be able to get the details of how fast or directionality, or if it's changing direction during the exam. So all the images are obtained by the ultrasound tech, and then they go to our to the electronic medical record. And this is where it varies a little bit depending on if you are having a diagnostic radiologist read the study or if it's a point of care ultrasound, which is what people can use. Clinicians have been trained in it outside of radiology, and they can use it in real time. So if you're having a diagnostic examination in the radiology department, it goes to the radiologist to read. And well, what is a radiologist? I explained a little bit about my training, but all radiologists are trained in a similar way. They all have to go through med school. So you have 4 years of med school. They all have to complete 1 intern year after med school. Some will do it in general medicine, some will do it in surgery. And then they go into radiology residency, where you spend 4 years learning all about everything within the field of radiology. And so that means that you are rotating through rotations like pediatric radiology, neuroradiology, looking at the brain and spine, or breast imaging, mammography, and you're learning how to read mammograms. You're rotating through interventional radiology and learning how to do procedures by using image guidance. So all radiology residents go through these 4 years, and pretty much all programs are exactly the same in how they train, the amount of time they spend in each of these different rotations. And then almost everybody now does 1 additional year of fellowship. And that's where you become subspecialized training, whether it be in abdominal imaging or neuroradiologist or breast imager or pediatric radiology. There's different fellowship years for everything. But not everybody who gets an ultrasound is going to have a diagnostic ultrasound coming to the radiology department. And this is where the introduction of point of care ultrasound to the medical education has become really important and really useful. So now physicians that are being trained in using these handheld ultrasounds to apply it real time and use it as one of their options in their clinical toolbox to make a diagnosis. So internal medicine doctors are using this, family medicine, critical care, and more. I know I could go on and spend create a whole list here. So I just threw up a few, top 3 that came to mind. But this, the introduction of point of care ultrasound and using this for clinical care has been really wonderful. And they're looking at the images real time. They're taking the pictures themselves. They're seeing, is there blood? In a trauma patient, do I need to go on and get a CT right away, or does this patient not need a CT? Can we avoid it? So it's no longer just a radiologist who might be reading that ultrasound. If it's not a diagnostic, if it's just a point of care ultrasound, it might be the clinician who's treating you at the bedside. And then all those images, all the interpretation, everything is put together into a report, and that goes into the electronic medical record. So let's see here, just trying to make sure I'm on time here. What do we see on ultrasound? Well, we can see if things are fluid or a cyst, for example. This is an example of a kidney. And we see that there are these little areas of really dark, almost black signal here. These are anechoic. That's what we call really dark black signal. And it's fluid. So we can tell if things are fluid filled by ultrasound. Or we can tell if things are solid and have vascularity or might look more suspicious for something like cancer. This is an example of a uterus. This is an endovaginal ultrasound, so using that longer probe. And it's inserted into the vaginal canal, and we can see all the different components of the uterus here. We see there's a little bit of fluid in the endometrial cavity, but there's also this area of tissue that has vascular flow. This is that color Doppler image I showed. So you see little blips of blue and little blips of red. So something like this, we'd say, well, that's not a cyst, that looks solid, and that might be suspicious for cancer. So we can give information like that that would then say, well, you should probably go on to have a biopsy to see what the pathology is. We can use ultrasound for seeing things like stones in the gallbladder, like in this example. Here we have, this is the gallbladder, and because they haven't eaten, the gallbladder is filled with bile. So it's filled with fluid, but there's also this little bright echogenic structure here, and that's just a little stone sitting in the gallbladder, little gallstone. Looks so innocent, but can be very painful for people who might have had gallstones. And then we can use this in acute imaging. So like in the emergency room, you have a patient that comes in with scrotal pain, and you need to know, do they have a torsed testicle or a torsed ovary? And that's a surgical emergency. So we can make the diagnosis immediately by saying, well, one side has flow. Let's see if I can get my thing here. So this left side has flow, and we can compare the 2 sides on a side-by-side image and say, but the right side has no flow, and that's a problem. And that's why the patient's having pain. And they need to go to surgery. So ultrasound is a wonderful tool to make these diagnoses without having to go on to additional imaging and potentially reducing the need to go on to CT or MRI. And sometimes patients can't have CTs or can't have MRIs. You might have a contrast allergy. You've had a CT before and you broke out in hives or had an anaphylactic reaction. Well, we don't want to give you IV contrast anymore because we wouldn't want that to happen again. Or MRI, say if you have a pacemaker or a clip or a surgical clip from an aneurysm that's not MR compatible because it's a magnet, that might be a problem. So we might not be able to put you into the MRI in the magnet without potentially increasing your risk of having a problem related to that. So maybe we can make the diagnosis with ultrasound. So why is it great? It's non-invasive, right? We are just taking pictures from the skin surface. Widely available, pretty much available in almost everywhere. Or if you don't have it available, you can take a butterfly probe with you. And it's easy to use. It's typically less expensive, and I'm going to run through this quickly because I know we've already gone through some of this. I'll kind of expand on a few of these points. Safe, right? We have no radiation associated with this imaging, and we have the real-time images. So the great thing is on ultrasound, if we're not sure what's going on or what the images are showing us, we can go back in and take more pictures. On a CT or an MRI, we try to time it, especially if you're giving contrast through your IV. We time it to see, okay, where's that contrast going and how quickly do I need to image so I can see where that contrast is going. And if we miss it or mess up the timing, which happens because everybody's heart beats a little bit differently, or they have different function of their heart, or things just don't flow as quickly as somebody else, we can go and take more images. But in that situation, that's going to be hard because we'd have to come back and do the whole study over again, right? And we try to avoid having to do that. But with ultrasound, we can get some additional pictures if we feel like we don't have enough information at that time. And I mentioned first-line imaging for reproductive organs and superficial structures. Ultrasound is wonderful. What are the risks? Well, there's not really much in terms of risk. There are no documented known harmful effects on humans. The only thing I mentioned here is particularly in pregnant patients, there is a theoretical risk of heating associated with the ultrasound. It's something that we call a thermal index, and we've known about this for a long time. And the way that ultrasounds are performed in patients that are pregnant are done in manners so that their thermal index never reaches any sort of level that has ever been associated with any sort of poor outcomes. So that would be the only potential risk I would mention with ultrasound, is in that very specific, patient population. Limitations, operator dependent, right? If we can't get the right pictures, we can't make things appear. If things are in the way, we can't see it, we're going to be stuck. And so operator dependence, not getting the right images we need, or things in the way, bone, gas, or a lot of soft tissue, that might be trickier for us to get the pictures. We need to make the diagnosis. Okay. Any questions before I kind of go into other directions of ultrasound, of what we can use it for? That's been a lot. No? Okay. Well, let me talk briefly about what can we use ultrasound for when we're doing interventions. So far, I've made a lot of discussion. We've talked about how can we use it to diagnose problems, but how can we use it to help us treat patients? That's another factor that we can use ultrasound for. Well, we can use it to help guide us to an area of fluid or abscess that needs to be drained. So if we can see with ultrasound, we can watch in real time and make sure that we're putting the, whatever drainage device or drain or needle, we're able to get it right into the area we need to go and take the fluid that we need, whether that be for sampling or to put the drain in so that things can continue to drain out and it can heal. We can use it for biopsying masses. If we can see it, we might be able to see if there's a certain part of the mass that looks really scary, and we might know, okay, I want to make sure I get that tissue versus the fluid part of it, right? Because I want to really know what this is, and I want to have the best chance of making the diagnosis versus having a non-guided biopsy where you just biopsy random samples. You can also use ultrasound for medication administration. So there are clinical trials out there for things like melanoma patients where we can use chemotherapeutic agents and inject it directly into metastatic melanoma deposits. And you can do very focal treatment, you know. Typically, we think of cancer treatment as systemic and all throughout the body, but there are some emerging uses where we can target specific areas and provide treatment directly to that area and not have to provide it directly to the rest of the body. And then if you need a catheter, dialysis patients, patients that are really sick and they need to have monitoring, we can use ultrasound to make sure that we have the catheter put in as safely as possible and in the right location, into the right vessel. So these are just a few examples of how we can use ultrasound to help guide us. And I don't know if either of you have seen anything differently from med school or heard about anything differently from, I'm trying to think if there's any other ones. Yeah, kept it general so that hopefully everything kind of falls under one of these 4 categories. And just to finish up, one other new emerging use of ultrasound is something that we call contrast enhanced ultrasound. And I know we mentioned contrast for CT and for MRI and how wonderful it is, because the idea of contrast is that we put something into the blood pool and we want to see where that goes. And that tells us information about how much blood flow something might get. It tells us how fast and quickly things flow to that area. It tells us if there's blood flow, and you know, things that are bad like cancer or infection tend to have more blood flow to that area. So we can use this to help us identify, is that really, is there blood flow to here? Is there really truly significant blood flow? And is that going to mean that this thing that I'm seeing on ultrasound is more suspicious than if I didn't have any information about blood flow? So what this is we can use a bubble that we put in through the vessel through a peripheral IV, and we can watch with ultrasound and we can see where those bubbles go, because wherever the bubbles go means that's where blood is flowing to. And the bubbles that we use here are really small. So this is just a little diagram of what it is. It's a gas-filled microbubble. It has a little lipid or fat-containing shell, and it's about the size of a red blood cell. So really, really small. This is like 2 to 8 microns. And when we inject it, we can then use ultrasound to take an image, and we can see in real time the bubble starts to oscillate or move, and we can see that movement as a picture on our ultrasound. And so here, for example, is that grayscale picture I showed you down on the left of this. There's an area, a mass in this liver right here. And on the grayscale, it's hard to say. As a radiologist trained in that, I don't know what that is with that single image. I know it's a mass in the liver, but is it cancer or is it a benign or non-cancerous mass? I can't tell the difference on that single image. But with contrast, I can see that this mass has areas of enhancement. It fills, it gets brighter directly around this area. And the center of it doesn't enhance right off the bat, but I can watch as it progresses, as more bubbles come in and fill the liver, that over time, this area in the center will start to fill in. And before I know it, everything is enhancing within this mass. It's all becoming more of the similar color of yellow. And with that picture, I can use my knowledge of how a liver mass would look on CT or MRI, because this is pretty much giving us an equivalent of a multi-phase CT or a multi-phase MRI, and say that's a benign mass in the liver. That's what we call a hemangioma. So don't touch, don't biopsy it. This is benign. It's not going to cause any cancer, has no cancer risk. So being able to use this is wonderful. Why? Well, because if you can't get contrast from CT or contrast for the MRI, this is a really great option for those patients. So patients that have poor kidney function or renal impairment, we're going to be very careful about giving them contrast, because most of the contrast for CT and for MRI get excreted or get removed from the body through the kidneys. And if the kidneys aren't working, that's a problem. Then where does it go? It gets kind of stuck behind. And we don't want that. So in those patients that have poor renal function and they can't have contrast for CT or MRI, this is a really great opportunity. If we can see the image, if we can see the mass by ultrasound, we might be able to make the answer. And same thing as I mentioned before with ultrasound, if we don't get enough information on those first set of images, we can pop the bubbles and go back and re-inject. The injection is so small. We have to wait for. We'll be out on time. Nobody will be stuck behind in the library. Okay. So if we need to get additional pictures because we feel like we didn't catch it at the right time, unlike CT or MRI, we can just go back and take more pictures, do another injection. We have to be able to see the lesion or the mass by ultrasound. That's one of the requirements to doing this type of study. And some people have additional training in this and feel more comfortable doing this, whereas some other institutions or some outpatient clinics, the radiologist might not be comfortable or have all the equipment necessary. And really the only limitation is if you've had a prior allergic reaction to this specific type of contrast agent, which is extremely, extremely rare. The amount of contrast reactions to this agent versus CT iodinated contrast or gadolinium, the MRI contrast agent, is extremely, extremely small. And this has a really great potential role for things like obviously diagnosing things that we don't have the option of doing a CT or MRI. It has great opportunities for intervention. So if we're trying to biopsy something and we keep getting non-diagnostic or unclear results, we can maybe use that agent, the contrast agent, to see where's enhancing what has the most enhancement and where can we try to, get samples from at that site. And targeted treatment. There's been ideas of, well, maybe we put treatment inside the bubble and we pop it right where we need it to go, and we can give treatment right at that exact spot. And same with the targeted, injections. Maybe we can avoid giving the chemotherapy agent or some other treatment to all the other parts of the body that might have problems associated with it. So, yeah, question. It has to do with the physics of the ultrasound. We put it on a higher frequency, and so there's more oscillation, and then the bubbles pop. It's asymptomatic. Like, you don't feel it. You don't even know it's happening. We can see it because we start to see all that yellow contrast starts to disappear, and it goes back to the gray picture. But there's a way we can do it with the ultrasound without causing any damage to the other structures too. Great question, thanks. So really great opportunities, and I really am excited to see where contrast enhanced ultrasound goes in the future. And last but not least, point of care ultrasound. So I mentioned this a little bit before, but this is just simultaneously performed, interpreted ultrasound that is then utilized by that single individual healthcare provider. We are incorporating it into our medical school educations. That's across the country. More and more schools are using this to incorporate this as a diagnostic tool as our medical students are rotating on their rotations in third year and fourth year. Many of them have access to one of these butterfly probes, and they can go around and see common pathology or common abnormalities and see what it looks like by ultrasound, so that when they're out there, when they're finished with their training, they can feel comfortable to use this to make diagnosis and help treat patients. And so these are just some of the examples of how we use point of care ultrasound. Typically, it's very focused. It's trying to answer a very specific clinical question. If you have trauma patient, you want to see if there's blood in the abdomen or pelvis. You can stick a probe on the patient's belly and see, is there any free fluid that would be concerning for blood? Or they're having chest pain and they're really sick and you're wondering, is there a pericardial effusion? Is there fluid around the heart? You can put an ultrasound probe on and we can show examples of the heart and see, oh, there's fluid there. Maybe it needs to be drained so the patient will feel better. Or maybe we can see if it's infected. Need to put a line in, like a vascular access. We can do that and so much more with point of care ultrasound. So I've said a lot. I will open this to questions. I obviously am very passionate about this, so I hopefully saved enough time for us to show some examples of scanning. But before we do that, anyone have any questions that I can answer? Have I personally used? Yes. I actually have not had the classical focus ultrasound training because as a radiology resident, we were trained in doing the full complete examination and scanning with our ultrasound techs. So if you have any specific questions about the education, I would highly recommend asking Ruthly or Gaston too, of what that's been like as a medical student going through the training. And when I was going through training, POCUS was not as widely used in medical school. Great. Okay, well, let's do some scanning, yeah? Okay. Feel free, if you want to come up. We're also going to display it up. Yeah. But if anyone's feeling brave and wants to try, you can do it. You can come on up and give it a shot as well. I'm gonna leave this. Good? Okay. Good. Have all these different settings with the ultrasound to say we're looking at the abdomen, or looking at cardiac exam, and that gives us a little bit finer detail of how deep we need to penetrate, but how deep the picture provides. The amount of different rays and things. So put the gel on, right? So we already have some signal that we're getting back, but this is obviously an artifact. So really what we do is the great thing, and I love it for the residents too, is so wrong, just put it somewhere on the abdomen and start moving it around and see if you see anything that looks like structure. There. So and again, these butterfly probes are a little different than what we have in our diagnostic side of things. So the image quality typically have by thank you for not. And I don't know, I wish I could. The black structure. Yeah, we can have somebody like that.
Yeah.
The team effort. I can also see things like the vessels and liver. So these, can you point out the hepatic vein? This is, I'm not testing you. You can be strong, actually. And I can see things in the portal thing. That structure centrally that has really bright sunny. I can tell on the ultrasound what's happening portal vein because it has different. I'm going to show you gas. The feared enemy of it. You show you go up a little bit higher. All that shadowing. You're like, well, that's very bright, but what is all this stuff right there? Time probe, the sound wave hitting air, and it's not going through. It's causing all of this stuff behind it, and so that's why. Oh, but when it's going to be. And there's a kidney. The right kidney. All the way down to the bottom part of the kidney, the inferior fold, all the way up. Systems, stones, See, there's something that's the aorta. Aorta. Blood vessel that takes all the heart, all the blood from the heart, all the way down to the lower part. So we can tell things like, is it too big? You might be at high risk for having aneurysm. Hooker, history of adverse thrombosis. So we can use this essentially as a screening. Keep an eye, make sure your aorta is not growing in size. Here's into the vessel. Leg. Sounds wonderful. Does anyone want to? You get tired of. Yeah, let's try one more. It's just for time, because I know this. Oh, sorry. You know, for our students, they're scanning each other. They should be really good at saying, like, if you turn me this direction, you're gonna get. Yeah. They did have to put the probe on and scan around, like, what am I looking at? But then if you're looking at too. And oftentimes it's be very difficult. I'm just rotating it around, trying to see if I can get all the four fingers. The other imaging, there's no. Obviously, we need detailed views of all the different valves, flow, and patients not asking for flow. It was part of the, but I need this fast. Surgery because there's physical access or software. I guess if anyone has questions, we can just like open it up. Feel free to move around. want to come up here and see it, you can. If you have questions for me, I'm happy to answer.
Yeah, while they get set up, I was gonna say, this is gonna kind of be our gradual official closeout, just to make sure we get out before the library closes. Thank you all for joining us for several mini medical school sessions. We hope to see you next year. I will be sending out kind of a feedback form. We'd love to have you fill it out just to give us feedback on how we can do better. Other sessions you might be interested in or that kind of thing as well. For people who have attended 3 or more in person, we do have certificates and mini medical school swag. So please go see Amber if you've been here for 3 or more sessions. But otherwise, thank you so much, everyone. Hope to see you next year.